Okay, now we are on the screen, and in cancer treatment, as you know, we have to distinguish between different problems. First is the agent, that means the product and the biological. The other side is a host, and the third is the host agent or host biological interaction. And my task is now to talk a little bit about the conditions of the host in cancer treatment. And liver disease are global epidemiology. We have more than 500 million suffers from HPV infection, for example, and we have a lot of patients developing cirrhosis and fibrosis. In 1 out of 4 deaths in the world is due to liver cirrhosis. And also the problem is that liver cirrhosis is the most common non-neoplastic cause of death in Europe and US among disease of the GI tract. And human cancer, liver cancer, is the number third in the worldwide human cancers all over the world. And why is liver so important? Liver is so important because it's a central organ, and it covers not only metabolic hemostasis, but also metabolism, distribution, storage, and synthesis in liver. And the diagnostic algorithm to test liver diseases is as follows. We go stepwise. First and most important are the clinical findings. And the second is then laboratory analysis and imaging. And then the other steps are following, like immunological, virological, genetic markers, and last but not least, if we have no answer to the diagnosis, we go into histology with all the different approaches which are possible. So why liver cell is so important? Because we have an enzyme localization, which represents on one side cholestasis parameters, on the other side transaminases, as we have synthesis parameters for albumin, for example, and coagulation factors, and we have cholestasis parameters like cholangiocyte and the cholangiocyte representing. And these combination between the different markers is very easily to do, and we can compare, for example, an increase in ALT levels. This means in first time hepatocellular damage, or we have most increase in the cholestasis markers like alkaline phosphatase. Then we have cholestatic disease, and we can also have a mixed type where we have both of these diseases. And last but not least, representing those transaminases levels, we can differentiate into different diseases. For example, acute viral diseases with very, very high extended transaminases levels. We have more milder diseases, and we have already also patients with not so much increase in the transaminases levels. And these are representing most difficult diseases like liver cirrhosis or even tumors. And how can we strategy with indirect markers a little bit more? We can use nowadays non-invasive fibrosis scores. For example, here's the fibrosis scores for FAB based on age and the thrombocyte and ALT levels. And we have a good correlation between the FIB4 markers and fibrosis stage in very early and very late cases. This is an indirect value, but it is important because elevated liver-induced values represent increased mortality. It is not a harmful problem, the elevated transaminases, but they represent indeed a higher death risk if they are higher. And this is responsible, for example, for the family doctors to focus on that. And how we go on in the diagnostic algorithm. As I told you, we begin with clinical symptoms, and the next stage is the indirect markers like laboratory analysis or imaging and elastography. Elastography is a new approach for liver diseases. We can use it for measuring of fibrosis or steatosis, which are very, very important for the damage, for example, also from cancer treatment. And then the next step is to look for immunological, biological markers, for example, in PHT or in programmed death inhibitors, which already induce autoimmune Okay, what is fibrosis? Fibrosis is a sonographic measurement, a sonographic method, which is very easy to learn and is short to examine, bedside, and is high reproducibility, and it also gives a good elasticity and fibrosis stage. And in the early cases and the late cases, we have a very good correlation for about more than 90% in specificity and sensitivity in this assay. And it also correlates with direct markers like the hepatic venous pressure. And then we have an indirect marker using FibroScan to have an HVPG equivalent. So we can use it in a non-invasive assessment. We have different problems. We have the confounders in those problems. This is liver inflammation, congestive of the liver, and steatosis, and this can be used and measured by elastography, either on vibration transelastography or in magnetic resonance elastography. And we, on the other side, we have other markers which represent more the inflammation and or more the thrombocytes and the synthesis of the disease, or even we have the problems of the different scores. So with these different categories, we can characterize the liver function. If we look into the past, into the future, we have all over the years a lot of good markers in the beginning. We have some markers like MELD score or FIB4 score, as I already told you. We were very happy to have it, but then we have seen that it's not all the reality. And then we used other markers like MEGIX test in the late 90s, early 2000s, and but they also were not at the end very helpful. We get into depression with these markers, and now we have a new hope that we have new markers to measure liver function, like the LIMAX. This is a maximum capacity of markers, which I explain now to you a little bit more. So hepatology is still alive, and we have still a lot of things to do. And the new marker and the new assay for measurement of liver function semi-quantitatively is a LIMAX procedure, as is here in the screen. You can see we inject metacytine. This is metabolized especially in the liver with the cytochrome P, P1H2 metabolism, and then we can measure it in a screen the exhalation of CO2, and then we can have a curve like this after injection. Then we have a rise in the curve with the reperfusion of the first metabolism of metacytine. And then we have the second step where we can the long-lasting evaluation of the liver function can do. And so we have three different categories. We have patients with a normal function, which have a high titer in LIMAX assay. And we have those with an impaired liver function, which are in the middle, and we have those patients with a very bad liver function, which are below 100. I will show you now some examples. But indeed, liver is specific, measured by this test, and we have a good correlation with the liver function. This is already the machine. Now some data, for example, for monitoring chemotherapy, it is helpful, and you can see that if we have LIMAX impairment, this is dependent also on the cycles of oxaliplatin, for example. And we can see here patients with a healthy markers, and those patients with treated with oxaliplatin, they have impaired liver function, and this can be measured already while using this test. And we also can see that if after chemotherapy, here is the diminished, the impaired function used measured by LIMAX, we can see after the cessation of the chemotherapy, the markers go better and the liver function repairs. And so also in other conditions, it is helpful to use it more. For example, in the ITU units, we can do it during narcosis. We can measure it. We can use it in the septic conditions. And we have in patients where on the intensive care board measured with LIMAX assay, we have seen that in patients with impaired respiratory stress syndrome and also impaired with very, very bad LIMAX assays, this was a patients which had which were non-survivors, and we could predict non-surviving using these markers. And as you can see here, there's a very good discrimination between those patients with a low titer in LIMAX with less than 100 and those patients with a high titer, which are survivors. Last but not least, we have investigated several stages, and we have in our unit we have done a correlation between the LIMAX and different diseases, and there was a good correlation. For example, between the LIMAX assay and which is getting in normal patient more than 500 and those with liver cirrhosis, which are very, very diminished. And the correlation is related with statistical measurements. So phase 1 and 2 diseases are very well discriminating from 3 and 4. That means we have patients with a good disease, which can discriminate from patients with bad disease, with high sensitivity and high specificity. And also we can discriminate this assay using the 90 days mortality rate. And so LIMAX was always the best marker to predict liver function at all. Then we have correlated LIMAX also with histology, and we have a broad spectrum of diseases investigated using this. And in all cases, we could manage a very good discrimination and correlation between the LIMAX value and the histology. And as you can see here, we have also this done in not only in an internal standard group, but also in an operative resective group. And these both collectives of the surgery and the gastroenterology group was comparable. So this is an independent investigation between surgeons and gastroenterologists using the worth of this assay. So taken together, LIMAX indeed is in all groups, maybe in fibrosis F1, F2, F3, and 4, always the best marker representing the liver function test in concern with non-invasive tests. And finally, we have used also the assay in patients with acute or chronic liver failure, or with patients with liver failure at all. Here, for example, a patient which came in with an acute liver failure. You see here a very bad LIMAX marker, 176. We have then treated the patients. It was an acute liver failure due to alcohol, and then the LIMAX 1 week later was much going up, and we have seen it maybe 4 weeks later after the injury. Then the LIMAX has normalized and it was regenerated, and this holds on 3 months after the first event. Liver was completely normal, and the assay, the liver function assay, was completely restored. So to discriminate the both groups, we can clearly show that between survivors and non-survivors of acute liver failure, we have a sensitivity from about 80% and specificity about more than 90%, with a cutoff with 80 microgram per hour per kilogram to discriminate between those which survive acute liver failure or which have to be transplanted. Last but not least, this is the case with acute liver failure, and you can see that the LIMAX assay was the first one which was going better in concern or in relation to MELD score, for example. It was much more better than the MELD score. And even in patients before and after TIPS, we have just published this. Is it helpful to use the MELD score? We have patients with before TIPS, which had a good liver function, and after TIPS, then the liver function diminished, and we can clearly discriminate those which are good and helpful for the decision making in TIPS assays. And also, last but not least, a patient with autoimmune disease, acute young girl with a very high titer acute hepatitis, fulminant hepatitis. and high bilirubin, and this patient had a very bad LIMAX in the beginning. We did already treatment with steroids, and you can see in a short time the liver function completely restored, the liver function completely get normal, and was get normal also after the cessation of the steroid treatment. So it is very helpful also to monitor patients during and after treatment, whatever you do, maybe also with programmed DAS inhibitors. So in summary, LIMAX test is very specific, shows a linear correlation. LIMAX test is a good finding in different indications, acute and chronic, and surgery, and also in monitoring for chemotherapy. It is applicable ubiquitously, so we can use it all over the world and bedside, and we can use it also to good therapy decision making or to prognosis assessment. Taken together, when do we use the LIMAX in the algorithm? After clinical symptoms, after laboratory analysis and imaging, then we integrate the indirect markers like elastography and LIMAX before we use the invasive markers at all. And the finding is we did an Essen algorithm now, and we can differentiate clearly with using this assay between cirrhosis and non-cirrhosis, using the LIMAX assay, using elastography, and this is an approach which is already published in hepatoma research. So finally, the LIMAX is in our hand a good screening tool, a good quantitative function measurement. It is good for monitoring liver-specific treatment methods, also in cancer treatment. And he's also good in management in very, very bad conditions like sepsis, and also in interventional treatment like TACE or SIRT. So we use it at all in all patients with liver cirrhosis. But taken together, however, we have to take into mind, we have to avoid bad diseases like cancers, and we can also only do it if we use if we change our life cycle, if we normalize our body weight. So that means if we avoid metabolic reasons, if we do sports regularly, and if you avoid smoking and alcohol, and if you use vaccination all over, not only liver-specific vaccination with HPV, HIV, but also in our times now in the pandemic with COVID vaccination in liver patients. And last but not least, after the webinar or during the webinar, you can use a cup of coffee. This is very good for your liver. Thank you for your attention.